Welcome back to the Little Spark Big Impact podcast, where we ignite the passion of pediatric providers like you. I'm your co-host, Mica Mitchell, here with our co-host, Joe Schreiber. And as pediatric providers, we play a pivotal role in a child's development. We educate the support system that empowers caregivers, and we celebrate every victory, no matter how small. Each episode will dive into different topics and the latest research to help you make an even bigger impact with those you work with. Whether you're a seasoned professional or just starting out, this podcast will hopefully give you ideas to support the positive impact you can have on the lives of the children and caregivers that you have an opportunity to work with. Our goal is to spark deeper thinking, reflecting, and learning from each episode. Today's episode, we will be discussing motor development, and we are really excited that we have some guests with us. And so I'm going to bring them into this podcast space and introduce them to you. So we have Reggie Harbourne that is joining us, and we have Stacey Dusing. And welcome.
Hi, nice to be here.
Thank you for the invitation. We're excited to be here.
Yes. Joe and I were like, okay, what are some topics that we want to talk about? We absolutely need to talk about motor development as pediatric physical therapists, but who should we have? And when Joe Schreiber came up with the list, I was like, yes, absolutely. Please, let's see if they are available.
Yeah, it helps to know really famous, smart people.
Yeah, I wish I knew some.
Yeah, we do. Yeah.
And so you guys have been on the forefront of motor development research. So thank you for everything that you have added to this field and into pediatric physical therapy. And can you share some of your most exciting recent discoveries? And more importantly, also, how do you envision these translating into real world improvements for kids that we treat? Because, you know, you could have this research idea, but how can we reimagine that into practice?
Mm-hmm.
Either one. If you want to go ahead, Reggie.
Stacey, you want to go ahead first?
Oh, either one is totally fine. Okay, I'll dive in. So I think one of the most important things is that the pediatric therapist working with young children is actually that we have to consider how parents interact with their babies. And so generally, as an educator and a physical therapy professional for 15 plus years, I am amazed at how little we talk about that in the curriculum. That really what our goal is to get families to provide everyday, all day intervention to kids if we're going to really make change. We know that the dose of intervention that we need for kids to have is very high, but we can't ask parents to be a physical therapist all day. We need to figure out how do they set the environment up? How do they build their interaction in a way that supports the child's development? Yet we don't talk about that very much in our curriculum, nor do we look at it in the evidence and how we provide intervention. Rarely do we measure parent level changes. We measure the child level changes. But if there is no change in the parent, do we really expect there to be changes in the child if our method of delivery is via parents? And so I think there's a huge deficit both in our literature, but also in our education in how we provide that support. Because you can have both a positive and a negative impact as a therapist on the interaction between a parent and a child.
Absolutely.
Yeah. And I became really interested in cognitive motor interaction as I was doing just a lot of pediatric physical therapy. I've been a pediatric therapist from the get-go. And I did all the special motor training things you could do, NDT, etc. But I came upon one person who really challenged my thinking in talking about learning, that all we do is really about learning. So that really pulls in the cognitive system. And then as I got interested in this sort of how all the systems work together, I decided to go into developmental psychology for my PhD and realized that so many things I did not know and did not consider as a PT were really cognitive. So I think it's something, again, that we haven't covered a lot when we do our basic education of pediatric physical therapists. I don't think there's a lot out there in terms of continuing ed that helps people understand what's going on in the mind of a child, how can we capitalize on that? It's not just movement. It's why would I move? Why would I do that thing? And also making parents understand that as well. So trying to sort of read the minds of the child and the parent to set things up like Stacey was talking about. And that's not easy for a new grad. First of all, they're all about the hands-on, and they don't really understand. It's not so much of the physical things you do, it's how you think. It's how you problem solve what's going on in each particular situation. So I think that whole cognitive motor interaction is just my my contribution to kind of open the door to that. Maybe not solve it, but to open the door, that's a big important thing.
Yeah, I would love to actually add to that, that I think Reggie has brought that really to the forefront in pediatric physical therapy, that, you know, cognition and motor go hand in hand. And one of the biggest challenges I see the intersect between kind of what I was talking about with parent-child issues and hers with cognitive motor is that that's hard for physical therapists who have an advanced degree to problem solve. How do I get a kid to think and move simultaneously? Yet in our early intervention system, for example, we call a parent and say, do you have any concerns about your child's development? And they say no. And we say, okay, we'll call you again in 6 months. Or we watch the kid work in a lot of environments, and we watch them play, and we expect the parent to be able to say, I have concerns about X, Y, and Z, without first saying, do you understand that, like, if the child is not able to move around, they actually can't explore the world in the same way. So it might impact their thinking skills, or helping our families see those intersections. And so in addition to the therapist needing to know, they need to know it so well that they can teach it. And if we're relying on service coordinators to call families and find out if they have concerns about delays, those people need to know this information too, because otherwise we're saying to families, well, we're not going to give you the basic facts or informed information to make an informed consent. And so we're asking parents to consent to something or to consent to not having a service when they don't actually understand why. We wouldn't do that in the surgical world, so why do we do it in PT?
That is a great point. And I think, you know, hearing what you guys have brought up forward about, you know, it can't just be the hands-on. It can't just be, you know, I've learned all of this content in PT school and I am a movement specialist, but really valuing all the other elements that make up who we are, and then the families that we're treating and the children. And I think part of this conversation also needs to be that it's okay to slow down your expectations, because I think as clinicians, we have high expectations and we want it fast and quick. Well, sometimes in order to do what you guys are recommending well, we have to be okay with maybe this one treatment session, it doesn't even go to the depths that you want, because you are really teaching and sharing and helping people make the connections of, yes, motor and cognition absolutely go together. If this kid doesn't even understand, you know, where it is you want them to go or why, or, you know, bringing that curiosity into it, the life of a child is curious. So I think those are some great points. It's okay to slow down your expectations, and, you know, we have billable things to do, but there still is value in what your research is showing that we should be focusing on in addition to our movement.
Yeah, I'm curious. So, you know, I sort of grew up on the opposite end of the spectrum, right? It's like top down, like I'm the movement expert. I observe, I put my hands on, I show you some things, and you try them as a home program, and then we come back and talk about it. And that feels a little bit off from what you're recommending or what your research shows. So how do we move people like me who've been in practice for a while, and even not so long, you know, relatively newer therapists who have the same kind of mindset? How do we move them towards this direction of linking cognition and thinking so much about what we're saying and doing with caregivers and with parents?
Well, I think it is really, it's hard to get this information out there. I mean, we have this sort of things that we do, which is to publish papers to give conference talks or posters, and to teach in entry-level programs. But when our students then go out to the clinic, what they're seeing isn't necessarily the latest research. They're seeing things that have been passed down forever. So it is really difficult, I think, to change people's behavior. And I think we also, as people who are trying to do that, just like with children, just like with parents, we have to think about it incrementally. I mean, look how long it took people to just like wash your hands. People still don't wash their hands. So, doctors don't wash their hands, and we know that that's so important. I think COVID maybe did it to us. Like, oh, let's have a giant epidemic, and people will wash their hands. So I think some of that incremental information can come through almost in the opposite way when we're converting a few sort of change makers, people who are truly senior clinicians, master clinicians, who then can influence people sort of in a small way, because I just don't see that many people responding to the written word when we publish something. I think it's hard for people. All those things like journal clubs can really help. But when you step out of that journal club and then you go rush to see the next child on your schedule, it's hard to keep that in mind. So, I mean, I don't really have the answer for that whole implementation piece. I think we need more research on exactly how to do that. And we need to take it from, okay, we found this thing out, these facts, these ways to do things. Now, how do we get people to do it?
Yeah, I couldn't agree more, Reggie, that we need more work on the idea of implementation and how do we get things out there to people and into practice. And along with the idea of implementation, I think the idea of de-implementing things and saying there is evidence this does not work, you need to stop doing it. We are doing a disservice to the profession by continuing to do things that we have evidence that they're not effective. And so we won't have space in our curriculums or in our clinical practice to start doing the new things that do work if we continue to say, oh no, keep doing these things that we have evidence for not working. So I think those two things have to go hand in hand, that we have to de-implement the same time we're implementing. And while I agree that we don't have enough time for clinicians to read papers and get information out there, we need to make sure that we are accepting things at conferences for presentation that are high-level evidence, so that people can the clinicians get to see what is the high-level evidence that's out there, that's happening, and then talk about how do you get it to happen in practice. I run a symposium every other year as part of my faculty position that is designed to bring clinicians and researchers together. And this year's symposium, one of the comments or one of the questions I got from somebody in the audience was, how do I find continuing ed courses that have this information? Like, you're teaching us the cutting edge evidence. We have international speakers talking about what is best practice in kids under 2 years of age. She said, I'm going to workshops on things like BMI because I can go and do hands-on training on BMI. And I get to do stuff and touch the kid. When I listen to your talks, they're just talking. And there's nowhere to go do that as a continuing ed. And I feel like I need the hands-on to practice it and do that. And it was helpful for me to think about, yes, we're providing things in web-based platforms as much as we can to reach more people, but maybe we have to have these courses and we have to have some hands-on to get people to go and buy into them. And maybe that's got to be part of the implementation process and the de-implementation process, is to make sure we're offering both kind of approaches to things, because I think the companies that are putting out non-evidence-based intervention, they're pretty good at marketing it and getting it out there to both parents and to providers. And that's a real disservice to our profession.
You guys said so much, so much to unpack. And I think that absolutely is a struggle, because there is this vicious cycle of, in academia, it's, well, I'm a clinician. I'm a clinician at heart. And I came into academia having practiced for, a decade and a half and more now. But I know when you're in it, kind of like what Reggie talked about before, when you have a family and a child in front of you, like there's so many more elements to this than let me take you through the chapters of this book. And then, as an educator, what is going to be on this national exam, right? So there are some things that we feel like, and at what point do those things shift? So I think this definitely this conversation needs to continue in spaces where people are making these decisions to know like there is a disconnect. And then that unlearning piece. I've had students that have said, you know what, I go in a clinic and I've seen things that I thought I wasn't paying attention in peds class because they're doing stuff that you didn't even expose me to. And I'm like, wait, so I lean in more, like, tell me more. And I'm like, well, there's a reason why we didn't cover that. And I think, where is that professional conversation and expectation and shift to how can our learners, our new clinicians coming into clinic, like if we're teaching them, what's best practice, but then they're going into a system where there's still a hierarchy, and then they're conforming to, I'm just going to do what everybody else is doing to make this peaceful, instead of really empowering them to say, hey, your default could be, let's go to this evidence. Let me tell you what Dr. Dusing said. Like, that should just be the end all, right? Like, what did Dr. Harbourne say, period? Like, just keep moving forward. But I think just even encouraging that dialogue and growth of, hey, guys, maybe we all have some unlearning to do this better for our patients.
Yeah, I would actually love to also hear kind of your perspectives as educators as well. And the idea, one of the things that we've been trying to do, I think, in the literature, and I think Reggie will agree, that the push is to really say, how do we look at what are the key principles of intervention? So I'm not trying to sell you my intervention package, but I want to help people see this is the key principles that we need to interject within our intervention to make it move forward. But I get actually a lot of pushback on that from clinicians, that they want the exact, how do I do this in this instant, in this example? And so when you're talking about a student going out to the clinic, if they have the theoretical background and they have the key principles, but they can't then apply them into the clinic to that individual case, how do we do that? And I think, Reggie, as you and I have trained interventionists for our clinical trials, it's the hardest piece, right? Is that they'll say, I have to think so hard during my intervention session to actually get myself to do this when they're first learning. Even these experienced therapists who are learning a new intervention, they're thinking really hard to apply those key principles and think about different scenarios in which they can do that. But how do we make that easier for clinicians, or encourage people that it doesn't have to be a cookie cutter approach? It doesn't have to be exactly this intervention or that intervention. But if we have an overwhelming body of literature that says exploration, active movement, parent engagement early on, 3 simple things of those have to be the key tenets of your intervention to have efficacy. Why is that so hard to get embedded into our world? Like, how do we make that move forward without giving people exact answers?
I think it's also just every learning is like this, right? Even babies learning, any kind of a new thing you're learning, if you're going to learn, let's say, a dance or an instrument, you don't do it fast and furious at the beginning. You do it very slowly. You can almost see people thinking. You can see this processing going on. You need that processing time, which I think clinicians are sort of thrown in, and they don't feel like they have that processing time, especially, with children, because often the parents are there and they're looking at you and they're expecting to see some magic happen. And so you just start doing things with your hands because you can puppet a child, you can make them do stuff, right? So I think that part of the transition or implementation piece and making it smaller increments is to have people understand the slowness of it, the slowness of learning something new. So yeah, you can't go in and do a whole session like this. Do it for 10 minutes. Think about it for 10 minutes and communicate about it. Like, this is going to be something new. and I have to think about it. So I think that communication and talking is really important. That's the other problem, though, that we have even with our trained interventionists, because we have to make sure they're doing what they're supposed to do. And some of it they have to talk about, or I can't see what's in their brain, why they're doing something. So hard to talk while you're doing. And so that's another thing. We should have students and people who take our courses practice talking about why you're doing what you're doing. I don't think people know what they're doing a lot of the time, why they're doing what they're doing. They're just doing something they saw somebody else do. So,
but that's great knowledge of it's okay that it's going to be ugly. It's okay that it's not going to be right. And I do try to encourage my students to know it's going to be ugly. But you know what? You're looking at this beautiful thing, right? And you may see a clinician do it in a beautiful way, but guess what? They had to practice. They had to fail. They had to mess it up. They had successes. They had to, that metacognition of figuring it out and just really understanding that perfection, that can't be the goal. But I believe, and I have felt that pressure of I have to be this perfect pediatric physical therapist. I have to be this perfect physical therapist. And this person's coming to me and they want, some knowledge or something from me. Like, this has to be worth their time. But I think just shedding that is going to be perfect has helped me as a clinician to say, you know what? And being honest. I may not get this right the first time. This is what I think is going on. This is what I would like to try. And I think just normalizing that I feel like it's helped me. And you get that buy-in because the families are going to fail too, potentially. Like, we tried this and it didn't work. It's terrible. Like, well, okay, well, let's talk that through. And to what you said, Reggie, like talking out your why and being okay with asking why. Why are you doing that? And not in a bad way, but why? Tell me more.
Yeah, I think the other people say perfection is the enemy of progress, right? If you come in thinking if you don't do it perfectly the whole time, you're never going to learn. You have to keep doing it and say, it's okay that it wasn't perfect, and that telling families that both you're struggling, like you're working on getting better at it, but so are they. And so if they practice correctly a little bit and provide these opportunities for the child to learn, that they'll make progress in that direction. But they shouldn't give up and just revert back to the easy thing because they've already learned that all the time. But it is a challenge for sure.
So can I'm like sort of, what is it? So that like, if we talk about like working with an infant or a young toddler or a little bit older child, in each of those stages, like what is it? What, like your research, the sort of cutting edge that we know about motor development. I think Stacey, you did mention, a couple kind of key tenets or principles, but like if it was perfect or close to perfect, like what should we be aspiring to, I guess?
Yeah, I think for me, the biggest things that I have to think about is that we need to see small, constant increments of change. So I don't expect large increments of change in what kids are doing, but we want to see variability in what they're practicing. So they're not doing the same thing over and over and over again. And that they're constantly making very small steps forward. And as a result, we're challenging them to make gains, but that are small over time. I'll give you an example of that. Many therapists will say, oh yeah, go put your baby on their tummy 30 minutes a day. They might fuss, they might cry during that time, but it's okay. They just need that practice. I fall in the exact opposite realm of that if you're putting them flat on the floor and they're screaming and crying, the task is too hard for them. Use a system where we can put them on a wedge, do it on your chest, make what you're asking them to do easier so they're successful for 20 minutes or for 10 minutes during a block of time, 3 times a day, so they can practice this idea of lifting my head, interacting in a way that says to that baby, this position is actually functional for me and I can learn. They get a longer period of time with a lower challenge level that we would call kind of the just right challenge then for that baby on that given day. And to do that, though, that requires that as a therapist, I'm actually going to see that kid again pretty frequently so that I can help the parent progress what they're doing. Or that I've given the parent an idea about when you see your child be able to do X, then try this. So with a really clear cut, kind of which comes first, what's the order, and when do you progress it? And so I think setting things up so we're looking at this really just right challenge today and not a big next step that the baby is working towards. And I'm talking about young babies. You know, I mostly work with kids under 6 months of age. And so looking at that as a way to set them up and then using the social system to drive motor development. So Reggie talks about cognition, and I couldn't agree more, but with our really young infants who are under 6 months of age, for example, their primary goal in life is to socialize with their parent or their caregiver. They really are driven by that engagement with a reciprocal engagement with a parent or a provider. And so using that as another way to set the environment up to say, practice playing peekaboo with your baby in different positions. Be prone face to face with them on the floor so they can practice in those environments. And I do think that it's making sure that the family understands that social engagement is what's driving the kid's motivation to move. And that's going to drive it. If we don't support their social engagement and their really tight dyadic relationship with you, then you're not going to actually see the motor change because they don't have a reason to move.
I also wanted to just to piggyback on that and the incremental change. So I think we do get a little bit driven on, let's use the same example, prone for a young baby, but we can fill in the blank with just anything, right? So whatever skill, whatever motor skill it is, what's involved in being on your tummy for any length of time? Do they care that they're on their tummy? I mean, they want to be able to look around. So that's a cognitive task, scanning, right? Being able to scan your environment and find what you're looking for. Maybe it's a social partner. Mm-hmm. Maybe it's a bright toy. Maybe it's the dog or the cat. But that's something else that you can add to your goal. So not just prone for 5 minutes, maybe prone for 2 minutes, but while you're there, turning your head to actually follow something. So maybe they can only do it with their head straight. Maybe they can only turn their head a little bit. Maybe they're not engaging with anything. Maybe it's so hard they can't really engage. Mm-hmm. But that can be a piece of the goal. So really you're combining all those areas of development, social, emotional, cognitive, and the motor task is a piece of it. But I think we tend to just get really hung up on, we got to get that motor skill and then everything else will follow. No, it doesn't follow. It's embedded. It's always there. You can use it. You can make it a piece of the goal. And then the parents can understand, oh, okay, just because we're not going from, 2 seconds of prone to 30 minutes of prone, we've gone for 30 seconds of prone when they actually looked at me in the face or when they actually saw me when I was coming from the side. So just there's a million different ways you can build that skill and make it important for the child, right? So I think you have to add in those other pieces.
Can I follow up then? Like, what have we been doing as a profession that we should stop doing with this same age group?
Yeah, that's a good question. I'm just going to keep talking for a minute, Stacey. I know you have a lot of thoughts on this. Sorry, I'm talking now. I think we need to stop that real hard focus on the amount of motor, whatever, time, frequency, number. I think we need to build in the other pieces of why you do those motor tasks as part of the goal setting and the teaching that we do to the parents. And also add in that it's important that you be able to do something in more than one way. So maybe you can be prone on your mommy's chest. You're good with that. Now can you be prone on a little pillow? Now can you be prone on the floor? Now can we put you on the couch while we're watching TV? Can you go over my leg? Can you kind of be flexible in that skill? I think we ignore a lot of those because we're jumping from developmental milestone to developmental milestone and just shoving the kids into position, and that really is not, useful, and especially if they're making them cry while they do it. Crying, nobody's learning anything when they're crying. Let me just say that.
Right, I could not agree more with that statement. If they are screaming and crying, they are not learning. And so any intervention that is there, I think is a challenge, and we need to kind of drop that approach to it in looking at it. And so I think for me, Joe, one of the things that I find the hardest is looking at babies and children are supposed to be playing, right? And so for me, play is the first part of intervention, not the second. And so one of the pieces is that kids need to be able to play, but we as therapists need to know how to be so flexible on the fly that we can say, yeah, this is play and you're interested in this task. How can I make that task in a way that just a tiny bit of a shift that you are still working? And so you are getting a dose of intervention that's working on a skill that may be motor and cognitive together, but it's 100% embedded in play. And then how do we teach parents that that's what's happening in the session? Because I know that there are therapists who are really good at this, and the parents are like, they just come over and play with the baby all day. They don't actually do any therapy, right? And so making sure that we're talking with our parents to say, did you see that small change? Like I moved the toy 3 inches to the left, and now we've got the baby practicing reaching with the left arm instead of the right arm, but we didn't take the task away. They're still thinking the same time they're now using the arm that we were trying to encourage them to use. And so we're able to integrate that into their routine, but the child chose the task. You set the environment up to make it so that it's a little bit more therapeutic in terms of your goal, but it's still about the play and the relationship that the child has with the toys when you're playing with a toy. But I think of socialization as a play form as well. So if it's playing with the parent and getting the kid to laugh and giggle back and forth or to play hide and seek, we know that builds cognitive constructs as well around that. So making sure that you're articulating, though, that that's why you're doing what you're doing so that a parent can think about replicating it. But I think that play has to be the framework with which we start this. And a lot of the work that we've been doing recently, looking at and having therapists actually talk about what they've done in terms of play. And like we just finished a study videotaping therapists doing intervention and then meeting with them to have them watch the video with us and describe how they're playing with the baby and if they're playing. And it's amazing to have them go back and be like, well, I thought I was playing, but like I'm forcing the kid up on their hands and knees, and then I'm forcing them to look for something, and watching a therapist like take a kid who's reaching for a toy actively and say, no, you can't do that because now you're out of quadruped. Like you started to move onto your tummy instead of staying on your hands and knees. But that child was reaching for a toy to interact with the world. Stopping that made that kid not only not think, but they also weren't playing, and then you get a crying kid. And so having therapists start to practice this skill of they need to observe more of what the child is trying to do so that they can allow for play and thinking to be the forefront of the intervention versus the backside of the intervention, or something they're going to learn from moving.
I just want to say one thing, going back to Joe's original question about inhibiting or de-implementation. That method of videotaping yourself and then watch, if you don't want to be, critiqued by anybody, you don't want people to look at you and see what you do, just videotape your own self and then go back and watch it and see if you know what the heck why you did what you did. It's very eye-opening. Even Berta Bobath, I saw her one time present at a conference because I'm really old, and she was watching a videotape of herself. It wasn't a child, it was an adult hemiplegic, and she just started to explain what she was doing, and at some moment she just went silent, and she was like, I don't know what I'm doing there. I don't know what I'm doing. I don't know why I did that. And it's really, I think, a great tool to get yourself a little bit out of your comfort area and maybe think a little bit differently about what you want to do when you're with that child the next time. So.
Agreed.
That little spark for big impact. The sparks that you guys have just been dropping secondhand, like no big deal. But I think everything you guys just said, if anyone is listening to this, like these are gems because it will allow you to grow. And the child choosing the task, I think that's so powerful. And knowing, when it comes to play, I think too, where we talked about perfectionism, however you think this child is going to interact with that toy, I guarantee you that's not how it's going down. And to be okay with not letting them interact however they see it, and having that appreciation, but then based on what it is you need them to do, then you kind of not restricting them, but helping them along the way with what they have chosen, I think is just so important.
So one of the things I didn't hear on either end was about like the primitive reflexes as a sort of overarching framework for development and change. And Mica had mentioned, students come back from the clinic, and I've heard a few times, why didn't we learn more about the STNR and how important that is, and that sort of thing. So I guess I'm curious what your perspective is on like the concept of primitive reflexes and what we should sort of be thinking about as educators and as clinicians related to that.
Well, I would just love to throw them out the window. I don't feel that they're useful for anything. I know they are embedded in some standardized tests, particularly for infants. So fine, learn those so you can score them. But that's not the be all and the end all. Those tests have a lot of items on them. One of them being the more important thing of, can the child voluntarily move themselves at all? What kind of movement do they have? Which is so way more important than primitive reflexes. And the whole idea that you can, what do you do with it? Once you see them, then what do you do? There's nothing you can do. Inhibiting them doesn't do anything. It's part of your nervous system. There's no movement passive or anything that you can do to disappear them. So there's nothing that it leads you to really do this big examination of try every primitive reflex. I mean, they're cool. It's like a nice little parlor game. You bring in a newborn baby and, oh, look, they have a grasp reflex. Oh, look, they, whatever reflexes you can elicit in whatever age child they're in. So fine, recognize that they're there. But honestly, I think that there is almost by now a decade of knowledge that those things exist. And then the assumption that they somehow mattered, that they somehow, like normal movement built out of them, which we now know is not true. Normal movement does not build out of them. They're just part of our nervous system that sits there and nothing. It doesn't really contribute necessarily to anything. But, it's just like those things that we were talking about, they sort of stay in the ether of things that have been recognized, but they're not helpful. So, yeah. I
would agree with Reggie from most of that standpoint. The only thing that I would add is that they are helpful in saying, does a child have neurologic dysfunction in some capacity? But there are other tests that are better at that, right? So yes, you can look at whether the kid have primitive reflexes. So yeah, if you have a 2-year-old who still has a persistent ATNR, yep, you know what? They have neurologic damage. But the Hammersmith Infant Neurologic Exam would have told you that and given you predictive abilities to looking at things. If a kid has a head lag, that's a better predictor than having an ATNR is. And so I think recognizing that piece of it, that they're done as part of neurologic exams by neurologists, by developmental pediatricians, and that's their context. But when we're seeing kids to say, what are we going to do treatment-wise? We're not trying to get rid of those. It's a reflection of their neurologic system having issues if they're still present at an abnormal time. But again, you have other tests that are out there that are much better at identifying that than doing a slew of primitive reflex assessment.
Thank you. And Joe asked the question, but this is a question that I had to like feedback that I was getting from, seeing things, in some social media spaces
Mhm.
and having students come back and not in a judgmental way, but they were like, Dr. Mitchell, like you set us up wrong. And I'm like, actually, no, I do feel like I was doing the right thing. So you guys have helped confirm that. But I think being able to hear it and say it in a space where we can have this dialogue. And I would open this up to anyone that wants to continue this conversation because I think that's how we grow. And so, you know, you guys have sparked all kind of stuff with me. I'm like, there's follow-up work to be done. I'd like to have all those references and resources to share, but you've seen the positive impact that PTs can have on children and families. And so we're going to wrap up our time today, which makes me sad, but all the good things have to come to an end. So what's one piece of advice or a spark that you can offer to our listeners, both clinicians and researchers, to help them make even greater impact in their work?
I think movement is just one part of a very complex system that we happen to be really good at, but we need to calm down about that. And we need to really consider all the aspects around that child. So, the parents, the environment, the child's interests, the cognition, the need for play, the perception of the child. Sometimes it's just the child has no idea that they might be able to do that they might be able to reach that far. They never did it before. And so you have to incrementally show them. So just that consideration that movement is a piece, maybe not even the centerpiece, but a piece of this very complex system surrounding a developing child. And we need to just broaden our attention to those relationships of all those other areas at every level of development. We've talked a lot about infants, but I think I can think of loads of examples of things that I didn't understand when I was treating a child. I'll just give one because I think we have a few minutes, but of a teenager who was very severe CP, smart boy, had athetoid CP, was just for the first time at the age of 14, put in a power wheelchair. And my job was to figure out how he could, things that he could reliably move to activate it, because his movement was very unreliable. So we were trying, like a head, a foot, all these different switches. And I took him outside because we thought we had it figured out. He was very excited. He's driving in the parking lot. And I say to him, watch out for that giant pothole. He doesn't know what's going to happen when he runs into that pothole. He's never moved before. So just thinking of the things that a person needs to know and understand. And when you're moving through, it's a lot, to really think about. But for every single new skill that we're teaching a child, there's just this whole world of surrounding things that you need to consider, not to make it more difficult, but to make you more successful, I think, understanding that and talking about it. So movement just being a piece of something that's much more complex than just the movement.
I think if I think about the spark or the little things to take forward, for me, the idea that starting intervention early is absolutely crucial. And that might even be before delays are identified or a child is identified as being at high risk of having things like cerebral palsy. And I'm a huge advocate for the early detection guidelines that we can identify kids as having CP by 3 to 5 months of age. But I don't think we should be waiting to start intervention until that happens. Because when we do wait, even though we're talking 3 to 5 months, which seems really young, at that point, you're now asking a parent to change how they parent to interact with that child or that baby, versus if we had given them scaffolding from the time that baby left the neonatal intensive care unit, when they were already identified as high risk, as having a brain injury or having known biological risk, like being preterm. If we set them up to be able to support that baby in the first 3 to 5 months of life, where they're thinking about dyadic interaction, they're thinking about cognition intersected with play, by the time they get to the point where they get a diagnosis of CP, they're already prepared to support that child, and they may actually need less intensive services because you're not trying to fix something or change the interaction. I've done a lot of work following families every week in their home and looking at them from an assessment standpoint. Parents don't know how to play with a baby. And when a baby doesn't engage with them, which many kids with early signs of disability don't engage the same way, they do things to the child, like passive range of motion, or they put them in the crib and let them watch TV. And that's what they saw in the NICU was I interact with you when it's like time to eat, and the rest of the time I put you to the side. And we see that repeated in families at home. And if we don't set families up to support the baby early on, it's asking them to undo everything they've learned about interacting with their baby. So providing those early services in the transition to home and in that first year of life may actually support not just the need of that child right now, but actually set the dyad up to support each other over that kid's lifetime and allow them to look more holistically at the child's development like Reggie's talking about. Because a parent who understands by 6 months of age, oh, my baby's looking around at the world and learning things from that interaction, they're also more likely to be able to think about, oh, a power chair might give my kid access to the world and be able to advocate for their child outside of just the walking skill or outside of the motor skill and think more holistically about their child's development. So I think setting families and children up to maximize their development requires that we start really early and then be prepared to increase or decrease the needs based on their ongoing assessment and the ongoing presentation of that child and family over time.
Thank you. Thank you. Thank you. Thank you for joining us. Joe, do you have any parting words?
No, I don't. I really appreciate the learning today for me, and all the great work you both have done over the years. It's just really had such an impact. So kudos, and just really, really happy to have a chance to talk with you today.
Yes, we appreciate you.
Yeah, it was fun talking to you guys. Thanks for inviting us.
Very fun. Thank you for the invitation. We appreciate the time. Your ability to share this information with a broader audience makes it all worthwhile.
Thank you for joining this discussion. If you like this episode, please feel free to like and subscribe to the podcast and share your thoughts and ideas for future topics in the comments.